on this. So Reza, from now on, is a professor of pathology at the Cleveland Clinic. We did not overlap at the Cleveland Clinic. I met Reza after that. He's an academic surgical pathologist with expertise in genitourinary pathology, but also, he may have not advertised, but he has looked at breast and GYN, just in case you guys want to ask for help. And he's also a clinical epidemiologist. I did not know that. He is board certified in anatomic pathology, both in US, Canada, and Europe. So he has multiple options where he wants to work in the future if he needs to adapt. He completed his medical school in Iran, University of Medical Sciences in Tehran, and a Master of Science in Clinical Epidemiology in Canada. He did his residency in anatomic pathology in Canada, both at St. John's and at University of British Columbia. And then he followed by a clinical fellowship in surgical pathology at Washington University School of Medicine, Burns Jewish Hospital in St. Louis. Dr. Alaghehbandan, so Reza, has served in various leadership and administrative roles, including department head. So he's had serious department roles, pathology and laboratory medicine at the Royal Columbia Hospital in Canada. And then he joined the Cleveland Clinic in 2022, I believe, right? His primary research focus is on diagnostic and prognostic challenges in urologic pathology, with an emphasis in developing risk stratification system that aid in clinical decision-making for patient management and outcomes, particularly in renal and bladder tumors. So we don't overlap, since my favorite organ is prostate. He is frequent speaker at national and international conferences. He has authored over 140 peer-reviewed publications, and he's also the recipient of multiple teaching and philanthropic awards, both in Canada and in the States. And in fact, in addition to being just a physician and a scientist, he's also a philanthropist. And he has served as an International Academy of Pathology ambassador. He has a passion for global health. He goes frequently every year in Thailand to help hospital and low-income areas. And he likes to build capacity and highlight the improvement that pathologists can make for population with poor resources. He provides a lot of education and expertise in clinical services, and also is very much involved in translational research. His goal is to make a lasting impact, I would say he has already done that, in the world of global health and cancer control. And with that, I'm very happy to introduce Reza. He's going to give a talk on One Disease, Many Realities, Tumor Classification in Global Health Context. Reza, it's a true pleasure to have you here. Thank you.
Well, good afternoon. Thank you, Christina, for a very warm and kind introduction. It's a pleasure and honor to be here. When I landed it yesterday in your beautiful city from the aircraft, I could see how fantastic and beautiful scenery you have. So I'm really jealous of it. I mean, Cleveland is beautiful, but definitely not as beautiful as your place. So, and the other thing I'd like to mention is the civil rights, which started it here in this place. I'm a minority from Iran, and I had a privilege to work on women's rights and human rights in Iran, and that's the reason I moved to Canada many years ago. And so that is also very close to my heart. When you go back a century ago, the philosophy of life was more of a, what are your responsibilities? Nowadays, things change. What are my rights? So there is also always a balance between the two, so I really appreciate that. I know most of you probably don't sign out GU, and probably some of you may not even be much interested, as Christina and myself are, in kidney tumors. So I thought I should probably do a combo, something that will probably interest you. So I start with okay. I'm just trying to use this. I'll be talking a little bit about global health and pathology, and pick on classifications, the history. Specifically, I pick kidney because I know a bit more about the history of kidney classification tumors, and then, you know, a little bit of a combining the two messages. We are human beings. We are storytellers. You know, our ancestors were, you know, hunters and gatherers, and, you know, and we like stories. So I like to start with telling you and sharing a story with you. This is Maya. She's 33. I met her about 15 years ago in Vientiane, Laos. She's a mother of three. And when I met her, she was at a cancer center in Laos, and she was diagnosed with cervical cancer, stage 4. When I met her, the question that I asked myself is, as a pathologist, what's my use here? You know, am I going to making a diagnosis of end-stage cervical cancer, HPV related, which is unforgivable, and it's too late? And really, that was the first thing came to my mind when I met her. Non-communicable diseases are still bothering globally, all of us, most specifically the low middle income countries. If you look at the incidence of cancer globally, you know, it's going to increase over the next 10 years, you know, 1.5. And if you look at the mortality, it's going to double up. So this is something we're going to be facing. It's going to cost us a lot of money in terms of human lives. That's, again, you know, beyond explanation. And the region that I have focused mostly on over the last couple of decades being Southeast Asia, and I'll tell you why later, and also a bit in Africa, but that comes later. So this is Southeast Asia, and I'm just going to go back. That's the Mekong River. Can I use this perhaps? Okay. Did I?
The pointer won't work.
Okay, no problem. Then I'll closer to you. So there is a Mekong River coming all the way down from China, and it goes to the Gulf of Thailand. Thank you so much. Excellent. And then dividing these countries into different portions. And then in this, I'm going backward. This is the world capital cholangiocarcinoma. The reason it is because there is a fluke in the river. For the GI pathologists here and distinguished friends and colleagues, the fish gets contaminated. The local, which are mostly farmers, they get contaminated by eating a raw fish on a farm. And then patients present with palpable masses. They are not resectable by the time they get diagnosed. Okay, so you got a patient with cholangiocarcinoma, and then majority of them are within the age group of 40 or 50. Okay, compare it to what we have in the US, which is roughly 60 or 70, so they're quite a younger age group. And so when you look at one country in the region, Laos, you have a country which is, you know, quite a only landlocked, you know, country. There's no connection between Laos and other, you know, seas and oceans here. And you have a population of 7 million. And it's as big as Utah, essentially, if you want to, you know, compare it to the land area. This is the only pathologist in Laos, Dr. Panvilai, and she has not had a chance to take a day vacation over the last 10 years. So when I met her, she was the only one. She was making less than a flight crew member. And we are grossing an ovarian tumor. That's the bench gross. As you can see, it's like a kitchen sink. And that's how they store samples. And amazingly, at the end of the day, she has a smile on her face. She's a hero indeed. The country has one pathology department, or they call it a unit. And then this is a lady on the left side who is the only tech in the country, and the other one is a younger woman who is a volunteer person. That's how they store their glasses slides, and that's their library with a bunch of old books. Probably some of them are donated or given to them. And that's how they store their samples. So you see there is a bit of a heterogeneity in terms of transportation. And the reason for it is in that country, which is the only communist country in the region next to China, you have a global or universal health package for everyone, but in fact, that doesn't exist. Only people less than age of 18 or pregnant women get a chance to have that. And the patients are responsible for transporting their specimens to the capital VNT. And if you have money, you can take it. If you don't, then it's going to get discarded. So regardless, if you come with a bump or a lump on your body, the patient is going to get treated for TB first, because that's the most common. And if he doesn't get any response to the treatment, then we probably think about other diseases. It could be cancer or whatever. And this is the laboratory there. It's everything manually processed. It's about 2,500 surgical samples per year. And here it is with your block, which is almost not in a great shape in terms of the wax they use, because they're all being, expired material that's been given to the country. And she's cutting a block. And this is 2,400 cases being manually stained. This is not a frozen section. That doesn't exist there. And the question is, we do have this disparity and equity in the global cancer arena. So how are we going to tackle this? In order to tackle this, you need three elements. Number one, you need to get the right diagnosis in the right person at the right time. Once you have these three elements, you can have an effective treatment. You don't see Maya at a stage 4 cervical cancer, HPV-driven, unforgivable disease. Okay, so that's what that's the deal is. Now, speaking of the right diagnosis, because we are pathologists here, that's what we do. You need pathology and pathologists. And then what we do as pathologists, we come up with diagnostic criteria, prognostic values, predictive values, and that leads itself to tumor classification. So that's where the whole deal my talk is coming in shape, that what is classification really? So when I look up the dictionary, it says, classification is a systematic arrangement of categories and groups based on established criteria. That's fine. So we deal with classifications every single day. When you go to your office, you open your email, there is a spam and there is a regular normal one. Why? Because there is a classification algorithm in place. And take it all the way from your computer to the sky. I mean, when I was a child, I was looking at the sky. I'm sure you all did. And you say, wow, look at all these stars. Well, they're not stars. They're galaxies mostly. And even galaxies, we do have morphologic classification by Hubble. Okay, so I'm not going to go into that because that's not my expertise. I have no idea, but I just, I'm fascinated by that. So we do have classifications. Now, WHO has 15 blue books, okay? 300 types tumors been described, that's fine. And when you go to the introduction of the WHO, it says it's worldwide. It is for the global use. That's what they say. That's great to know. And then, of course, classification itself is a dynamic process, okay? Because everything is evolving, changing. That's fine. Now, of all these tumors, as I said, I know a little bit about the history of kidney. So I decided to share that with you and put it in the context of the global health and the story that I share with you. Now, the one that we know, I'm sure kidney cancers existed throughout the history of human being, okay? But then the only one that we know back in 1613 by German physician is that he described there is a disease in the kidney, which is not curable, okay? He calls it swelling of the back kidney, which has the capacity to throw the person into death and this and that. So that's in 1613. And later, the first case report of renal cancer was in 1810, by Miller. And this is another a German physician. And then the first classification was based on growth, fungoid and medullary and this and that. So that was in 1826. And a decade later, we do have a French pathologist who coming and studying the morphology of the disease alongside of classification, trying to classify these things. And then right after, of course, the famous Gravitz came, If you are in the audience and you come across clear cell renal cell carcinoma, the old name was Gravitz tumor. I mean, someone was still used it, probably Christina myself, although we are still young, right? And then Gravitz said, oh, clear cell RCC is really, he didn't know what was clear cell, he called it hypernephroma. He said, this is an intrarenal adrenal tumor. okay? And so he was trying to go to the origin of the cell. He was trying to find that out, and he called it, this is an intrarenal rest. But in fact, it wasn't, and it was just simply renal origin. So before 1950s, we do have multiple classifications. Life was much easier. 1903, adenoma, adenocarcinoma. Have a nice day. And then you go to 1919, things get a little bit complicated. 44, 45, this is all before the war, okay? And then when you look at these tables I'm putting here, one might think, is this really one disease and everyone is looking at it from a different angle and describing it? Is it one disease and many realities? We'll see. We're coming to 1981. This is the first WHO classification. I love this one. I'll tell you why. You look at the contents, 25 pages altogether for the entire renal tumors, okay? And this is what they had. Adenoma, carcinoma. Under carcinoma, you have RCC, and the next one is others. Perfect. That's great. And then I specifically, intentionally picked these two pictures. For you in the audience, most of the trainees, they already know this is an oncocytoma. They call it adenoma. That's fine. They meant that to be benign, okay? This is 1981. And then after 1981, about 15 years later, the Germans and the Americans also separately, they said, okay, we need to come up with a better classification. So the Heidelberg classification came up, and this was based on histology, EM, histochemistry, and they call things as benign and malignant. And then under malignant, they have clear cell, papillary, chromophobe, and so on and so forth. And then this was the base for the second WHO classification. So you have the second classification, and I want to get your attention to this area. It says cystic associated RCC, and then underneath that you have RCC originating in a cyst, and you have a cystic RCC. I'm confused. I don't know what that means. But guess what? That was the reality of the day, okay? So again, things keep changing. And this is the photo, the famous photo. Now, this time they're calling it oncocytic adenoma, in brackets, oncocytoma. I don't care. At the end, it was benign. You just keep, changing the name. And that's what we do, and that's what we need to stop doing, changing names, okay? So, and then looking at the sky, as I mentioned to you, and the story for me goes back to the Sanskrit story, the elephant in the dark, okay? Everyone looks at it from its own perspective, okay? You call this adenoma, you call that adenocarcinoma, you call it oncocytoma, you call it, I don't know, cystic what. So this is really goes back to that. And of course, different modalities came up. You went from gross to H&E to EM to special stain to immunohistochemistry, NGS, FISH, and whatnot. And in 2004, we have 10 entities, and one of them is XP11.2 RCC, okay? So that means the new technology brought that in. So that's the first time, 2004. And then the next one was in 2016. So almost 14 years later, we have a new classification. We went from 10 entities to 14, so it's growing. Bigger, and then you do have some changes in name, multilocular clear cell from 2004 became a neoplasm. Again, one disease, many realities. And then this is your 2016 classification. And then the next one, which is the latest one we have, it's this one. Look at the list. It's going up to like 25 plus entities in this tumor, in this chapter. All right, so let's put things in perspective. That's the first WHO classification, the second one, the third one, the fourth one, and this is the last one. So keep growing and keep becoming, more complicated and complex, not only entity-wise, but also changing names, which I don't really like that, okay? So let's step back for a sec. Let's go back to 1800. So back in 1800, it was based on growth. Okay, if the tumor was confined to the kidney, if it wasn't, if it was fungoid, it was medullary, it was in the base, cortical, etc. And then it went back to 1900, a bit more clinical and, histologic. And then it goes all the way on to current one, which are being proudly called, histomolecular, classification. So that molecular is that, a fancy word that, attracts, minds and this and that. So we'll talk about that. Now, if you want to know what's new in the 2022 WHO, there are multiple papers out there. I'm guilty of writing one, that's fine. But let me tell you what's going on. So you got some established entities. Some of them, they got a bit of a refinement. Some of them, they got a change in name. You got molecularly defined renal tumors. I love this one because it says molecularly defined. So if you don't have the molecular capacity, you shouldn't be really making that diagnosis. And if you're not making that diagnosis, I don't know how the WHO is worldwide and applicable to all nations and everyone else. So we'll talk about that. And of course, the emerging one, because we love dissecting. We love dissecting as opposed to lumping and making it more common sense. Okay. And of course, there's a distinct entity too. Now, the reality on the ground, the surgeons would like to know benign versus malignant, white and black, okay? Don't tell me between, I don't want that. I remember when I was a fellow, Barnes-Jewish Hospital, the GYN onc surgeon brought me a 27 kilograms ovarian mucinous tumor. So I had to take a truck to bring it to OR, to frozen section room. And you know what he told me? And he gave me that for frozen section. He said, Reza, don't tell me I didn't give you enough tissue. What he meant was that I would cut it and I would call it at least borderline. He wanted me to say benign versus malignant. That's what he wanted me to say. And at the end, guess what? I just call it borderline because I can't submit, 100 blocks out of that. Anyway, that's the reality on the ground from the surgical point of view. From our point of view, we are on a different planet. We want to split. We want to confuse. We want to make things complicated. We want to make things, and I'm not saying that's wrong, but it is right within the right context. So what I'm trying to say is that our classification has gone way out of context, and we'll talk about that. And this dispute and debate between the lumpers and the splitters are going to continue. I know Kristen and myself, we think the same way. We like to lump. And I know some of our friends and colleagues, at the table we sit and they love splitting. Okay, and I see value in both. Again, it's context. Now, let's go back to our global health. What's the reality of global health, the geopolitical facts? So number one, every country is different. You have different demographic, you have different, type of diseases, you have different capacity, you have different needs. In this country, the top killer for cancer is lung cancer. That's number one. In Laos, the top killer is cervical cancer. Okay? So there are different needs and different capacities. In this country, we do have HPV as a vaccine and preventative measures. In that country, getting a pap from a woman is a taboo. HPV vaccine is not acceptable. So there is a difference. Second, lack of human resources. You saw that lab I showed you. Expertise, one pathologist for 7 million people. Educational programs, we'll talk about that. Language barrier. You got a WHO Blue Book, which is in English. It's $120, okay? If you have the money to purchase it in Africa, are you gonna read it? Let's say you read it. What do you think about this molecularly defined chapter? What are you gonna get out of that, okay? So common sense. And then clinicians, surgeons, God bless them all. Even here, some of them, they don't even understand what we do, let alone a clinician in under-resourced country. And of course, something I struggle with a lot is health politics. Every country I visit, you need to meet with the Ministry of Health authorities, and there is corruption in place. There is second, agenda always going on. So don't get me started on that one. This is a map of Africa. You see, there are countries in this continent, such as Democratic Republic of Congo, Niger, they have less than one pathologist per 5 million people. You know what is the rate in this country? You know, we have about 6.4 pathologists per 100,000 people. Okay, that's our rate. Still, we're struggling in your institution, in mine, and everywhere else, recruiting. There is a huge demand for our job, okay? Huge. And there is, unfortunately, not enough pathologists out there. So there is a significant gap in pathologist patient ratio across the board. Take it from wealthy, economically well-developed countries to all underdeveloped countries. And then, as I mentioned to you, pathologists in those countries, in under-resourced countries, they have a very limited ability to get training. Maximum, they get training in a neighboring country for a year if they are lucky. And then, as I said, language barrier is another one. And then I just made a real, it's not a joke, $100, actually I check Amazon, it's not 120, it's 126, by the way. And then you got to pay for it. And if you're able to read it, and if you're able to comprehend, and you're able to apply it. So it's a challenge. This is in 2014. I'm in sub-Saharan Africa in Botswana. It's a country hit hard by HIV back in old days. So HIV is no longer the issue there. The HIV being controlled. What is the issue there is the second surge. You have a huge immunocompromised population. What it means, cancer. So they're very much so bothered with lymphomas, sarcomas, and the Kaposi sarcomas I've seen in that country, I never seen in any textbook, even any case reports. It's just incredible. And then they're trying hard to survive. 2.5 million people, 3 pathologists, one of them left, by the way. And this is what they're doing. I remember signing out cases there. I came across, don't ask me why, I came across testicular biopsy. First of all, that's a crime. You can't do that unless it's for infertility, okay? Testicular biopsy of a lesion. I remember I look at the case and I look at it and I said, oh, this looks like a Burkitt lymphoma. Okay. And I came across, I said, let's put that aside because this is coming from April. I was there 9 months after. I was there in November. I said, well, Burkitt lymphoma, probably a patient exploded, passed away. Would you mind calling the medical officer somewhere in that village? They said, yeah, sure, we'll do that. So anyway, 2 p.m. they came back and they said, hey, we just called something interesting happened. I said, what happened? They said, oh, the medical officer said, oh, it's really interesting. The patient was here yesterday asking for his biopsy. I said, God works in mysterious ways. Because if you make a diagnosis of Burkitt lymphoma in a patient in which the glasses slide does not belong to, okay, you're going to kill that patient by giving him chemotherapy if he can afford it. So the glasses slide was labeled wrong on a different patient. It completely messed up quality control. So when you go work in those countries, you got to be aware of that fact. So I said, you know what? Someone got saved today, but someone died of Burkitt lymphoma, God knows who. But that's the reality on the ground in that country. So this is the only cancer center in Laos. It's a former, French colony. The French gave that building. It's a 2-story building, 7 million people, 10 beds. And I visited their first time, 2015. It's a very desperate situation. This is the back of the cancer center. The families of those patients are responsible for maintaining and cleaning the cancer center, okay? And those patients come, they're end stage, they think they're getting treatment, they're just getting some saline. Trust me, I've seen it. There's no treatment there. There's no oncologist there. And they're paying for it, okay? And that's the only head and neck surgeon in the country I met. I'm shaking his hand. He's so gracious. He's working day and nights and trying his best. I met the only breast surgeon in the country as well. And I asked her, how do you treat your patients? She said, I'm giving everyone tamoxifen. I said, good for you. 85% of breast cancers are hormone receptor positive. So that's the right thing to do. But that's the reality in that country. And then on the left side, there is myself and Dr. Panvilai. There is a multi-headed scope. It wasn't working, by the way. It was a donation by Japanese people. God bless them. But at some point, whatever you donate needs to have a proper maintenance, but it wasn't maintained well. Anyway, a few years ago, I reached out to my colleague and friend who's the secretary of IAP, Dr. Zatari, and I told him, look, we got to do something about this matter of WHO. So we came up with this proposal. We presented it at IAP in Mexico, demystifying WHO in support of limited pathologies in limited resources countries. And this is been going on at the USCAP Boston. They had the second symposium. It was important to have it. And I think we're just going to carry on. Christina is incoming USCAP president and also the president of the GUPAS Society. So I'm going to use my friendship with her in a good way to push for that agenda, because the Blue Book is supposed to be for all of us. When I say all of us, it doesn't mean all of us in this room or in this country, all of us. So, and I'm not against technology. I'm not against advancing science. What I'm for is that we need to have it with common sense. We need to develop these books into more available to them to be able to use it. Anyway, let's go back to the kidney. So 2022 WHO Blue Book Kidney. The good news is this, around 90%, 95% of your tumors are going to fit in these three categories. 75% of them are going to be clear cell. You don't need IHC. You don't need NGS. You don't need anything. You just need a good H&E. That's all. The second one is papillary. We'll talk about that very briefly. And the last one is chromophobe. And the rest of those 5% esoteric, okay? If you are in, let's say, Ghana, and you have a very esoteric kidney tumor that you make or you don't make that diagnosis, the clinical outcome most likely will be the same as the one at UAB. Why? I'll tell you why. When you look at the latest, actually, clinical paper came out by our colleagues at MD Anderson, they're just saying, look, pick on one disease. The worst kidney tumor is renal medullary carcinoma, okay? Renal medullary carcinoma. This is the worst. That is still to this day, there is no treatment for it. Chemo won't work. There is no clinical trial. There is no targeted therapy. There is no hope for that disease, unfortunately. And guess what? This tumor is extremely rare. You may not even see one in your lifetime, okay? So the challenge with the Blue Book is that you coming up with entities that require fanciness, I call it. Fancy IHC, fancy FISH, fancy NGS. How many labs in this country, how many labs in this state have all those modalities? You tell me. How many? And then take that concept and apply it to the entire globe, okay? We're struggling with creating a basic, proper H&E in Laos. You saw the block, okay? And then someone tells me AI is going to help. I say, no, it's not going to help, because if you don't have the proper foundation, you can't build your building on it. The proper foundation is H&E, and that needs to be digitized. AI can help. If you don't have a proper H&E, how the AI is going to help me? How digitization is going to help me? Subclassification is only relevant, and I really love this, if it has any therapeutic implication. Go through the WHO Blue Book, see how many of those, whether you call it carcinoma or you call it tumor, has any implication for the patient. How many? We'll go through that together. And then the vast majority of them not even clinically relevant. If you call it RCC with blue picture, RCC with pink color, RCC with, I don't know, green ribbon, it doesn't matter. At the end of the day, the treatment is going to be equally the same for most part. And then, as I mentioned, some of them are extremely rare. They're not going to see it in their lifetime. Someone in Africa or in Asia. And as I said, these modalities are not widely available. Now, this is the blue book, and this is what I would propose in terms of making it simple. So you got 7, entities here, clear cell and papillary and this and that. What I'm thinking is that we need to risk group them, okay? So instead of going after the origin of the cell of origin, going after the prognosis, going after, I don't know, the ISC or the molecular and this and that, we need to see which one immediately is going to kill the patient, which one has the potential to metastasize down the road, which one has indolent behavior, yet we call it carcinoma, and which one is just essentially just benign. We just call them, tumors. So 4 categories. You need to recognize which one is going to kill the patient immediately in the next 6 months, and the ones that is going to metastasize possibly in the future 10 years or so. And then I just try to put them in different categories. These are coming from the blue book. And you can see that here, if you have sarcomatoid with any cancer, any RCC, that's going to be a bad news. Everyone knows that. And then those 3 entities, FH and this and that, those fancy names, they're extremely rare, below 0.5% of the tumors. They're not going to be so common. So don't confuse people in the world by those rare and esoteric entities. And then you go to the long-term metastatic risk. You got a clear cell papillary chromophobe. I'll touch quickly on those. And then the indolent one, which is going to be those entities. If you call them carcinoma or if you call them tumor, most likely the patient is going to, survive anyway. And the very low risk, I don't care what you want to call it. I remember Dr. Louis Lerner, who's a former fellow of Dr. Ackerman, the only living fellow of his time, told me, Reza, I used to go to Dr. Ackerman's, office, show him a case, and he would look at it and said, I don't care whatever you want to call it, it's benign. That's it. You see, that practicing surgical pathology still valid to this date. Of course, we've been forced into putting different entities in different boxes, because if we don't, we have almost like committed a crime, okay? But it's always important to remember putting things in perspective. So just a couple of words, bear with me, because, it's a ground round, so I need to show you some glasses slide of histology and to kosher the matter. So clear cell. So here it is. Classic picture. Okay, everyone can tell, no problem. And then, of course, tumor heterogeneity. You can get sometimes pink areas in it too. That's totally fine too. Sometimes you can get high-grade areas and rhabdoid areas. Sometimes you get areas such as this, like plant-like areas. You can get confused with chromophobe, okay? And then sometimes you can get sarcomatoid component. The whole tumor is sarcomatoid based on what you have. And then what's going to help you is that little, rim of, conventional clear cell somewhere. That's going to help you. No immunostain is going to help you. Sampling is going to be the key. So if I have that tumor, and if I have all wall-to-wall sarcomatoid, I already know that's not going to be a good news. If I'm pushed to put it in a category, I'm not going to spend 50 immunostains, each $50 on a case. I'm just going to go back to the bucket. As Christina said, the answer is in the bucket. So go back to the bucket. It's there. And you submit more and you get your answer. Years ago, we noticed that we need to publish something on papillary areas. This is a clear cell, has some papillae as well. So people are confused. Is this a mixed papillary and clear cell? What is this? This is another area of another tumor. Papillary on one side, clear cell on the other side. This is absolutely wall-to-wall was papillary almost. And, we did a study with our mutual friend, Andre, back old days. He passed a few years ago, unfortunately. And we did, fancy NGS on all these tumors. And we just showed that, look, guys, the key is this. If you have a tumor with a lot of heterogeneity of papillary, whatever, if you have a little component of clear cell somewhere, just call it clear cell. Don't bother, because the study is showing it is. What about papillary? All these tumors, they have papillary architecture. The question is, I asked the trainees today, I said, if you have papillary architecture, does it make a papillary RCC? And unanimously you said, no, it won't. And you're right, here it is. I have a papillary RCC on one side. I have chromophobe papillary architecture. Trust me, there is one too. And you have these amplified RCCs and this kind of weird, rare, esoteric, and of course you have the clear cell too. And historically, when you go back to 1997, Ebley and Delahunt, came up with subclassifying these tumors into type 1 and type 2. I don't want to bore you with that, but then the new study came out and showed that, type 2 is essentially it's a mixed bag of different diseases. And so, it's a classic type, 1 morphology. Nowadays, we try to call papillary RCC if you have this morphology, okay? It's a, it's a well-circumscribed tumor with a cyst fibrous wall and papillae filling in. It's a very low-grade tumor with macrophages and some areas, sometimes you can get clearing as well. So don't be bothered with that. That's fine. The key is that if you get sometimes calcifications and whatnot, the key is that if you have a conventional papillary RCC morphology anywhere, you can call the whole tumor papillary RCC. Sometimes make sure that, you don't miss the little hidden diseases. It's the patient with papillary RCC, and in the background, the patient has CLL. So don't miss that one. And this is a sarcomatoid RCC. And if I have only the sarcomatoid component, immunostain is not going to help me. What's going to help me? The sampling. Okay? This is a consult we received, and you can see beautiful papillary areas. So just call it papillary RCC sarcomatoid differentiation. Next case. And then, colleagues from Memorial published a recent study in ModPath, and they said, look, regardless of what you have in terms of the architecture and the morphology, if you have an area of your tumor with type 1 classic morphology, call it papillary RCC. So again, the same concept applies to clear cell, to papillary. Let's look at adenoma. This is I just put adenoma here, not because it's important, because I just want to make a point here. This is a little adenoma, innocent, and here it is. But when you go back to the history, it's really fascinating. Bell's rule was that if you have any tumor less than 3 centimeters, it's benign. Believe it or not, if you have an RCC less than 3 centimeters, that's not going to kill the patient. So if you called it in the past benign, it's not a crime. It's okay. And then the WHO 2004, had a definition of less than 5 millimeter for papillary adenoma, and then we changed it to 15 in 2016, okay? And this is an AFIP book that I have on my desk. Sorry for the quality of the photo I took by my phone. They measured it, that it says this 8 centimeters renal cortical adenoma. So an adenoma of 8 centimeters today is absolutely unacceptable. And today we will call it a carcinoma. And so I just want to tell you that, there's one disease and then multiple realities being, multiple, definitions and pictures being told. So it's chromophobe is another one, solid, and with this in complete septate, binucleation, distinct cell borders, perinuclear halo. In the book, it says, CK7 is strongly positive. That's not true. People rely so much on CK7 positivity. I'm just showing you 3 chromophobes all the way from black to negative. Bottom line is your chromophobe is just an H&E diagnosis. You don't need any immunostain. Just call a chromophobe, have the criteria, and apply it. This is an eosinophilic chromophobe, meaning it just has a lot of pink cytoplasm. That's totally fine. And the chromophobe has different faces. Sometimes they can get a little adenomatoid, gland-like, can be cystic, such as this one, can be papillary, like the one that I showed you. So, we also did a study on this, and, we just showed that regardless of what kind of a morphology you have in chromophobe, they're all the same. They're all the same in terms of behavior, except for the ones which are with sarcomatoid or necrosis. Simple as that. Okay, so what's the role of IHC in kidney tumors? So you got a kidney mass, whether it's a primary, it's a secondary, or it's a urothelial. If it is a renal origin, for me, again, I put it in these 3 categories. Killing the patient immediately, or immediately meaning 6 months, fairly quick, long-term met, and then the hereditary ones or other tumors, including that. So really, there is only a role for the very small proportion of all these tumors, which is about less than 5%, even less than that. And those three on the right side, the one with a lethal outcome, that you don't have the IAC in your country to do it, guess what? You're not going to come across them. And even if you do, you're not going to do much for the patient because there is not much of a modality in terms of treatment for those patients nowadays, unfortunately. For hereditary neoplasia, I put two entities there. Again, majority of them are benign. So they're not going to kill the patient. Going back to our story. So I have this 2,500 cases per year from a population of 7 million in this country, one lab. They're barely making H&E. And here is your diagnostic value chain that I put it here. The problem with diagnostic chain is either the patients are not aware of it, as I mentioned, HPV, cervical cancer is a taboo in some of the countries, or the clinicians are not aware of it, which is a universal thing. Or you have problem with personnel in terms of training, in terms of mentorship, et cetera, et cetera. And the answer to most of this is education. And the education starts with us, okay? And then the model that I'm proposing for education in pathology, because we are global, this is what I believe, without us, because we are the kingmaker. We make blue book, and the rest of the world follow that. So we better know what we're doing. Whatever you develop as a program, it needs to be resource stratified. It will be really silly of me or you to go to an under-resourced country to give a talk about NGS today, okay? And it should be operationally feasible. If you want to bring IHC lab to do specific fancy stain in a country, yet they are barely surviving with their own blocks and H&E, that's not feasible. And strategically it needs to be sound. You need to see in that country what they're struggling with. First thing first, you got to tackle that first. So once you have that, that should be based on all these three elements, the local needs and the local capacity. And once you have that, then you can call yourself, okay, let's come and then get some help and let's demystify these blue books based on this model for supporting our colleagues. This is in Laos 15 years ago. And then Dr. Pamvila is there. A number of colleagues from Thailand joined me. And today, Dr. Pamvila has 4 more colleagues. 2 were trained in Japan, 2 were trained in Thailand. We supported those 2 trainees from Thailand, and we call it educational twinning program. It means it is so expensive to bring someone from an under-resourced country to UAB because it costs money, number 1. Number 2, that person comes with a cultural shock, okay? Coming from, for instance, a different climate, a different environment, and you bring in that person here, training and sending back. Instead of that, go and support a neighboring country, which is willing and able to support their poor neighboring countries because they share pretty much the same currency, language, culture, etc., and you support them that way. So that's what we do. In addition to that, as I said, education is important. Here with my hero colleague, Dr. Supindar, who's in the picture, she's a breast pathologist in Thailand. In Thailand, in northern part of Thailand, the rate of triple negative was 33%. Triple negative cancer, that's unheard of. So what we did, we went back and to study what's going on. And we noticed that a mastectomy puts into a bucket with no formalin, travels 300 miles, come to the city center. And by then it's rotten. And you do your immunostain and you're proud to do immunostain and you report a triple negative. And the poor woman who needs to get tamoxifen gets chemotherapy. So she came up with this container, has 3 compartments, and the surgeon is trained to cut it in OR in 3 or 4 pieces, place it in this bucket, transfer it to the city center, and They're really good with technology. They put little chip in terms of tracking the specimen, and that's here it is. And then we brought that triple negative rate of 33% to 13%. That's right. You're saving lives. You're saving true lives here. And, just going and education. And this is in the growth room. We're really proud. We did a workshop, a regional workshop, bringing people from different countries and teaching them. One more thing. I'm a surgical pathologist. So as a surgical pathologist, I train in FNA cytology. I'm not a cytologist by board certification. I don't have it. I came across this man. He's 56. He's a farmer from northern Laos, bordering with China. And I look at his neck and I ask him, how long has it been going on? He said, over the last 4 months. So immediately I said, okay, whether this is a lymphoma or this is an anaplastic carcinoma, one of the two, can't be anything. It's not TB. Well, guess what? Lymphoma has a treatment. Anaplastic thyroid carcinoma, I don't think so. Okay. FNA, you don't have much of a histology lab. You don't have anything else to do that. So beautiful FNA, and here it is. This is an anaplastic, unfortunately, thyroid carcinoma. So non-invasive and fast and accurate procedures such as FNA, which is 95% is accurate. If you call something on FNA benign, it is benign 95%. If you call something on FNA malignant, guess what? It is most likely malignant. So I found out that in some of those regions, the ONSAT rate in cytology was 50%. Ridiculous. 50%. Why? And they keep blaming the pathologist. Everything I do is 50%, ONSAT rate. I purchased a kilogram of apple. These are surgeons. I took to the meeting with them. They said, oh, you're bringing apple, professor, to eat with? I said, no, this is for practicing. And I noticed they're using the 20 gauge needle to poke in that poor thyroid. All they aspirate is blood because thyroid is a vascular organ. And then we started teaching them, okay, you need to do FNA procedure. This is the right way to do it. And then we brought that ONSAT rate from 50%. The latest we had, it was about 20%. Still room for improvement, but from 50% bringing it to 20%, that's a huge improvement. And just going and the value of FNA in those countries. This is a grandma came with a thyroid nodule, and this is a man with a neck mass. Kid came in Laos with a midline, node, and the mom was so scared, and thank God it was just a lymphadenitis. It wasn't nothing else. The man came with a neck mass. It was unfortunately a metastatic adenocarcinoma. The grandma, I FNA'd her. It was a lymphoma. So I told her, you're going to be fine. So, and you're doing workshops in those countries because education is the key. You just not go with service. You need to educate the clinicians. That's important. Majority of them are clinicians in the room, and the gynecologists mostly, and you just try to get them to understand what pathology is and what pathology can do. So that's our role. And sorry, some of them are, and then meeting with the politicians. So I went to the US 3 years ago. I was in Canada. So you can see the Canadian flag there because I was on a different planet, okay? And then later, a couple of years ago, I went back, and then you can see the American flag is there because I'm now a part of Cleveland, right? And so they're proud, and you discuss these things with the politicians, and you try to buy in. That's what you need to do. And we did a lot of online sessions and conferences with those countries. I use social media. They send me a case. And, if I know it, I know it. If I don't know it, I'll show it to Christina. I show it to other people. I have a number of friends in the country. So I get the best experts in the world in terms of whatever, GYN, breast, cytology, GU, whatever. And then you provide them with that answer. So I use that as well. And then at the end of the day, we do all this because of these people, because these are our people, because these are our patients, because these are the patients who are sitting on the floor and worrying about their family and loved ones. And that's what the main deal is. And going back to Maya, So her mother asked me, of course, they don't speak English. She came and she said, I was with the suit and, tie and this and that, so going there. And then she came, she said, do you have a treatment for my daughter? And that was an easy question to get. And I knew end-stage cervical cancer is almost a death sentence, it's in the nose and all that. But what I promised her was this. I said, I don't have it today, but if I have it tomorrow, I promise I'll bring it to you. And the promise is education and looking after each other and seeing all as one unit. When my arm hurts, I can't say, oh, you're not part of me. Go deal with yourself. It's your part of your arm. You need to deal with it. It's the same thing. If a colleague, if a patient, if a surgeon facing a challenge in a country, guess what? It's all one family. And that's what it is. So I think education, as I put it here, is global, and so is pathology. We are important. And so we need to take it seriously. And I think in order to take it seriously, we need to remember that philanthropy is the essence of this drive. If you don't have it, the education and pathology is not going to be useful. You just keep going to split and creating, thicker and bigger WHO blue books, which is not going to be really useful to all of us. So with that, I love this point. I'll stop, and then I think we have a few minutes for questions. Happy to answer any questions.
Thank you so much, Reza. I have two difficult questions.
Okay.
The first one, how are we going to deal with it? Are we going to dumb it down or create a small font and big fonts, or red color and blue color, green color for different part of the world? The difficult question is the second one. Why are you doing this?
Yeah, the answer to the second question, I don't know. But for the first question, I don't have any authority over the blue book. But my humble suggestion is, I think we need those who split. I think we need those who lump. And I think we need to have both. We need to keep the science grow, but at the same time, we need to have the common sense and the context. So I really think the blue book should grow and grow, make a bigger BMI, that's fine. But then we need to create specific versions of those for specific countries. I'll give you one example. A few years ago, I was asked to be a part of the task force at the WHO to combat breast cancer. In sub-Saharan Africa, breast cancer, unfortunately, is still killing our young mothers and sisters and patients. So the task was the United Nations came and mandated the WHO to create this, the story of cervical cancer screening program that was successful. They wanted to duplicate that for breast cancer. So we got together. So I was one of the pathologists, and there you got oncologists, surgeons, senators, and I don't know, kings and queens and this and that. And then what we did was that let's create a booklet for a country that they can use as a guide in terms of screening, early diagnosis, treatment, and survivorship. Okay? And the mission was for decreasing the mortality rate by 2.5%, which is translating into roughly by 30 years, 40 million people. For every mother passes away from breast cancer in sub-Saharan Africa, around 3 orphans are left behind. 3. Okay? And those kids, they go into becoming sex slaves, abused by the society, being abused in different communities, hardship, work, etc., etc. And they also develop some breast cancer because of the genetics and the harsh environment. So I really think we need to come up with a version for a specific region based on the culture, needs, and capacity. When you go from Myanmar to Laos, believe it or not, it's day and night. Politics, infrastructure, rules, everything. When you go from Laos to Cambodia, completely different. When you go from Cambodia to Thailand, even in this country, you know, you go from urban setting, academic center to some, rural areas, some small community. I'm sure you get to see all these cases coming your way for review. And you come across some weird diagnosis. I come across even to this stage, transitional cell carcinoma. I'm okay with that. What I'm saying is that how outdated, what a significant gap we have between even within our own country. And then to the second question, I think at the end of the day, one has a conviction. So for me, I have my value system, you do too, we all do. I think my value system is that if there is something I can do for someone, I think it's an honor. It's not even a responsibility. It's not even a charity. And, I don't know what else I can say about that, but it's just an honor. So as it is an honor to be here to share with you those stories. Maya passed away, but I think it can, leave a memory within all of us here to think about it that, okay, my 20 cases of the day that I need to sign out to go home and come back and next day, this is one aspect of life, but this is not the whole life. There's a little bit more. And then if it can help, that's fine. And that help comes with a little bit of an intention, or, you take a trip and, if you can do something for someone. So I think it's equally valuable.
Another question in the chat that says, what do you say to the people out there who say pathology is food?
Yeah. You see, psychology has its own value and it needs to be placed in a proper place. For instance, let's talk about kidney. Do I believe in FNA of a renal mass? No, I don't. Okay, I don't. I don't think you should do any renal mass FNAs. Do I believe in FNA of a breast mass? Well, let's talk about that. If there's a breast mass in a country that you can get a core biopsy, no, don't do an FNA. If you can't get a core biopsy, yes, you should. And you should create a cell block because we need to stain it for ER, PR, HER2, send it to the neighboring country. So cytology is inexpensive, non-invasive, very accurate, and it's amazing. And it can be an amazing tool in an under-resourced country. I use it every time I go, and I can't say anything better than that about it. It's just an incredible, tool that we have in our toolbox to use.
Thank you very much for sharing your experience.
Thank you.
By the way, I will work on the status cytology